I'm hoping that the online people are, hearing us well. If there are problems, please leave, a message in the chat. So obviously, dementia is a collection of things. There is a lot of situations, but very, very important, I think, as an important message is that it's not part of aging. So what happens when we're at home and when we are in older adult homes and entities? Okay, we say a person has symptoms of dementia, and obviously it's part of aging. Okay, we need to go away into just targeting. Okay, that this is the situation. Obviously, the prevalence of the disease, of the dementia, increases. Okay, with age. Very, very important. Okay, there's a lot of causes. Okay, nutrition might be one of them, but it's very complicated and, to give evidence base on this. But most important is the morbidity and other medical conditions. Come in, come in. Okay, and obviously, as you know, Alzheimer's, okay, is the most common kind of dementia that we encounter on a daily basis. Bonjour. Okay. So what is the issue, okay, in terms, okay, there is no cure, okay, and what is the main issue? And the prevalence, this is statistics from our professor, related to the increase in the amount of people. And this means, okay, that we need to consider a lot of these activities of daily living, including the nutrition, okay, for this rise in the cases. Okay, so obviously today we could, easily conclude and have a take-home message and say that, okay, nutrition is important. So that's it, So my aim today is to try to get into, the stages, okay, of dementia. Okay, I mean, I'm assuming, okay, that you know that there are like it's a progressive, okay, there are a lot of stages, and obviously, when there are no signs of dementia, okay, nowadays we have even there might be also tests, genetically, to see that a person might be more predisposed to dementia. But my aim today is to focus more into the advanced part, okay, in the early stages of dementia and moderately, and how we need, okay, to tackle nutritional concerns in these individuals, okay. So when we talk about prevention, many times, okay, as dietitians, many people think that we need to give a nice diet, for weight loss, and that's it. Okay, many times people will say, okay, I want to have these kind of foods in order to prevent dementia. There were a lot of studies, okay, population studies, and in fact, these are more targeted in the, early signs. They are not effective in advanced stages. Okay, so this is very important to look at. And there were a lot of dietary patterns, that have been suggested in the literature. Okay, like our Mediterranean diet, okay, the MIND diet, the DASH diet, all these kind of dietary patterns. Oh, today I'm not going to, do a talk just on saying, okay, how healthy eating is important to prevent dementia, because this is very difficult to do so. Because when somebody has Alzheimer's and is genetically predisposed, yes, the environment might affect, okay, the dementia, but in reality, it's much more complex to control, and say, okay, I'm doing this kind of diet, these kind of diets, and I can prevent dementia. It's very difficult to do evidence-based practice on that situation. So today, what I will be doing is considering these two important words, okay, which is malnutrition, okay, and with nutrition, we need to couple hydration. Okay, in fact, very important, okay, because sometimes we forget the hydration part, both go together. And very important, malnutrition does not mean only weight loss, okay, because many people think that somebody is malnourished, okay, he needs to lose only weight. Malnourishment also means that certain vitamins, certain minerals are absent in the diet of that individual. In fact, one example that is very common is that if there is an infection or there is an event in a person who has mild dementia or early stages of dementia, many times they get confused. Okay, and the confusion is many times related to the malnourishment. Okay, because of certain vitamins or minerals are not there. For example, the B complex. Okay, the B complex is related a lot with like signs of dementia, and obviously the person is confused. They will be having signs and symptoms, and many times that means nutrition needs to be taken into consideration. What I will be doing today, okay, and it was like also for me a good review, is to go around, the guidelines of ESPEN. ESPEN is an important European Society for Parental and Enteral Nutrition. They're a group of people, okay, whereby they give recommendations, and this is, I think, related very well to my title. Okay, so which are the guidelines on nutrition, and as you can see there, they updated it from the previous one in relation to hydration also. And there are 40 recommendations. You tell me, my God, 40 recommendations. Okay, 7 at institutional level, and there were around, 33 at an individual level. And my aim today is to go through them, okay, and obviously from a discussion point of view, what relates, to those recommendations in terms in our Malta, okay, at our institutions. But before going that, let me give you a bit of a baseline, of why nutrition is important in dementia, okay? Dementia affects memory, and obviously memory and activities of daily living. One of the important activity of daily living is nutrition, okay? Feeding yourself. So we need to look at, older people who are at home, who are at an institution, and this is why the recommendations are targeting those both levels. Okay, it's a critical role. Why is it a critical role? Because with aging, certain normal functions of the body cannot be obtained without, certain nutrition. And nutrition does not mean only calories. Nutrition means also vitamins, minerals, other chemicals that actually are important for the body. One important thing that happens in older adult, what is it? That most of the vitamins and minerals are not well absorbed, okay, in an older adult. So imagine they have a poor nutrition, then they are not absorbing well, and this will definitely affect. So nutrition is not 2 days without any food. It means a long-term approach of a disbalance of these nutrients that are important for the body. Okay, the malnutrition and dehydration, as I told you, worsen, okay, I mean, the decline, okay, and the cognitive, and sometimes some people who have been in the first stage of dementia think that this is a very progressive thing. Remember, there are like vascular dementia, which is much more progressive, okay, and many people think, and sometimes when the infection is resolved, for example, or the, health condition is resolved, they get better. So it's a bit of an on and off situation. And very, very important, I cannot stress more than today, this is my take-home message, is that you need early nutritional intervention. Unfortunately, okay, the healthcare system is very, very busy, okay? At primary, secondary, tertiary, all are busy, and many times this early nutrition intervention is not done, and people are referred to a dietitian at the end of it when people are, lose weight. And remember, older adult people lose weight from the muscle mass. Okay, many times it's not just the weight in itself. So you can see an older adult who is maybe overweight, but the muscle mass, okay, is going down, and this is sarcopenia, which we know definitely affects the body. Okay, so how does malnutrition occurs? Okay, appetite, decrease, and many times we assume that we get older, we eat less, and there's no problem to eating more. But what we need to assess is how much will this affect the body composition of the person. Okay, weight loss is very common, and as I told you, weight loss occurs many times from the muscle mass. So even the weight loss is many times very drastic, like 5 kilos of weight loss. For an older adult to go from one institution to another, they go to hospital, they lose 5, 6 kilos, then they go back home, they lose another 5 kilos, and until we recognize, that weight loss, things are happening in the meantime until the medical condition is resolved. And nutrition is not that taken. I'm not generalizing, but in many times this might happen. Okay, nutritional deficiencies, and very, very important, how can we early detect nutritional problems is with nutritional screening. I will be going into that later on. So what we need to consider is, why is this loss of appetite? There might be, a lot of situations why people lose appetite. Might be they are depressed, they moved from their home to an entity with other people. Loss of appetite could be due to medications, that changes the taste, okay, of a person. So we need to identify why there is a loss of appetite. Okay, difficulty swallowing. This might happen when the stages of dementia actually progress. Okay, and very important is this recognition of hunger and thirst. This is actually a normal part of aging process. Okay, that the thirst, and this is why it's important, the hydration, is that older adult cannot just be left there on its own and just we push. Okay, drink more, drink more. Okay, that might not be effective. Okay, so we need to monitor and see, because the urge of this thirst actually declines also with the age. Imagine also with dementia. Okay, so very important to do things. And obviously, behavioral symptoms in the later stages can also affect nutritional intake, food intake. These are other situations. I'm not going that much because we have a cohort of people from different areas. But obviously, what we need to recognize at the stage of the dementia are the those situations where we can then act upon. For example, okay, olfactory and taste disorders. We need to see how these can be resolved. They can be resolved very easily because maybe the medication is temporary. But if there are other medications which they might be changed by a geriatrician or other allied healthcare professional who is taking care. So obviously, I mean, concluding on this part, okay, very important is that this goes into a vicious circle, and this is as healthcare professionals, as carers, and other people, we need to try to cut down this vicious circle. Many times we're not that much, we don't succeed. And this is not the because it's me or the other or the institution. The problem is the timing, the complications of the situations, okay, because the intake and the requirements might be affected by a lot of situations. The moment I have my mother, fractured femur at hospital, now she's at hospital, carrying Greg, there's no spaces, then she needs to go somewhere else. So this system in itself can cause, that certain aspects of activity of daily living, especially, okay, now nutrition, can be overseen. Okay, so if we don't have a structured, okay, approach, then it will be very difficult and very easily to lose this kind of thing. And obviously, very important when we go into these, I don't know if you know the wording sarcopenia, and cachexia, when there is like drastic weight loss. Okay, many times this is where we are flagged up as dietitians, and it's not very easy to change over, or increase calorie intake, just by saying, okay, let us just increase or give supplements and that's it. It will be very difficult to do it. So it's very important that you immediately you start, the process of screening. So let's go a bit through these, recommendations, because I think this is my take-home message today, to see that there's a lot of recommendations. I will skim some through, but these are part, as I told you, they are part on two levels. Okay, the institution level. So we need to look at quality assurance. Okay, what does that mean? We need to see at standards. Okay, what do we have? Standards. Are they available? Are they not available? Okay, so we need to look at this important. About staff, about carers, we know that many of the older carers are the main, person that are taking care of older people. Okay, so are they trained? Is there any training, involved in nutrition? Okay, the environment, okay, in itself is very important. Okay, don't leave people in their in their area, eating on the bed, this kind of stuff. So environment is very important, and what kind of food and drink provision we are giving them. Okay, this is an important area. From an individual, important is the screening. Okay, how we're going to support them, and I will give you a summary, of what these recommendations are having. Okay, if we give enteral or parenteral nutrition, enteral means okay, food through a tube, not food through the mouth, because it might happen that there is dysphagia, okay, which is difficulty in swallowing. So all these things are important. Should we give them at the Yep, very good. I will say it. I will say it. Okay. At the end, we can discuss then, definitely. This is the kind of important points that this document is stating. Definitely, I agree with you. Okay. And very important at the individualized approach. So we have both institutional dietitians cannot cover all people in older the homes, not even if we have, 1 billion of budget, to get dietitians on board. So nobody will get individualized. But very important in certain cases, individualized approach is very, very important. Now, before going on, I wish to disclaim, and say this, that, I will be, saying, I will criticize certain things, but it doesn't mean I'm basing them on evidence or it's a personal opinion. So if there's a recommendation and I say, okay, in Malta, this does not happen, this should happen, doesn't mean that I'm criticizing. I'm putting it as a discussion point to improve things. And at the end of the day, this is why we're here. We need to see what is available, what is not available, and how we can improve situations. So this is why I'm doing it, because you might, from the 40 recommendations, I criticize 30 of them, and you tell me, Lello, kollox ħażin. So, I mean, this is the why I've done this. So, at an institutional level, very, very important. Okay, there are 7 recommendations. Okay, one of them is that all organization they need to promote adequate, appropriate nutrition and hydration. Very, very, how to say, generalized. How you're going to do that? Okay, we have a caterer here in Malta. The system is outsourced, so there's no food being cooked in most of the institutions. So it's outsourced. What is inside that food? How much are our older people, in this case with dementia, are having from that food? What quality of food? At the moment, we don't have data on that, okay? Okay, reheating food, heating food, certain vitamins, minerals, proteins. Is there enough, in them? It's a big question mark, and it's an area of study that one should explore, okay? And that kind of thing. There should be standard operating procedures. We're not in the airport industry here, or in the airline system, but an SOP is important in order for people to have an idea on what they need to do. And as far as I know, okay, there is no standard operating procedure stating exactly if a person with dementia enters an institution, what needs to be done. Okay, usually in guidelines, in strategies, these are written down, but very, very generalized. Okay, like they shouldn't have imbalanced. Um, they should have balanced meals. What does that mean? Balanced in what? Okay, they should be provided food. Okay, 1, 2, 3, breakfast. That one, but what kind of food? So these are the questions that we need to ask. And the organization caring for persons should employ sufficient qualified staff for supporting this food and fluid. The support is very, very important. Now, I'm not saying that there's no support, but in certain situations, we don't even know if a person has dementia or not, okay, in our institution. So how are we going to support in that situation? Okay, so it's very important that people have this adequate support and how you're going to do it. Because today we can easily state these points, but we need to see how implementation is done. Is it done? Is it not done? Etc. Etc. From the experience of dietitians, many times we find there that this is not done. We don't even have sometimes records of people on how much they are eating. We need to either ask them, and imagine if somebody has like advanced dementia, either ask them or the relatives, which are not always there. Okay, because remember, relatives in older adult homes are not cannot be there with their feeding, right? I mean, we cannot be stay there whilst they are feeding, so we don't know exactly what's happening. We're not allowed because my mom is in one of the care homes. So we're not there. Okay, so we ask this stuff. We ask my mother. I ask my mother, and I said, did you eat today? And she told me yes. But what does that mean? Oh, question mark. Yo ma nafx. Okay, so definitely that's the situation. So very important. This is all related to staff education, and I think this is where I'm stating that there is a lot of courses being organized, for carers, and some of them are mandatory, if I'm not mistaken. But obviously, we need to target a bit more the food and hydration part. Okay, so we need to have a bit more education. I'm involved in some modules, in relation to nurses upgrading, to diploma levels. It's a module, but it's a general module on everything, not just specifically on dementia. Informal caregivers. So allied healthcare professionals needs to know, and sometimes this is even lacking between us healthcare professional. Okay, in terms of we work a lot with speech and language pathologists, physiotherapists, and other people. So sometimes we don't know exactly if we are aware of nutritional and cross referral with speech and language. We always work because we need them to do this following assessment. But with other healthcare professionals, psychology and other things, the structure is not that strong. Sometimes. So meals and drinks should be provided in a functional dining room, and I think this is something that all homes most of the time do. So in every level, as far as I know, everybody has a dining area. So I think that one is something that was always part of the standards and plan in Malta. And organizations caring for persons with dementia shall offer attractive food and fluid with choice of food, snacks, and drinks to support adequate. Here in Malta, we're lucky that many times if the relative, okay, if the person with dementia has relatives, they will be offering other food. They will bring food with them and everything. But we have a lot of also a cohort of population where they have no relatives or they have a problem with relatives and they don't come and see them. Okay, so this is where we need to have the organization offering extra foods. And again, the question is what kind of food to offer as extra. Okay, because a packet of biscuits is one thing, and having something which is more nutritious might be a completely different scenario. So basically, the 7 at an institution level, this is the kind of thing. Obviously, we have nowadays a standard authority, which is very good, okay, to have an older person standard authority. And I think as a society, as allied health professionals, we need, to be in communication to when standards are being formulated. Okay, standards means that you have a guideline, you have something, that you need to head on, but it doesn't mean we need to see how much of it is implemented. We're very good in Malta, okay, sometimes to do standards and, strategies, very good, nice. But then we don't have the stuff or the time, to see if those were implemented. Okay, so this is something that we need to look at and obviously do them. In fact, when I was doing this research and I went into, for example, OPSAN in the standards and wrote nutrition or diet, they were mentioned like very generalized. They should provide food, they should provide balanced meals, which means in reality, what's that? I mean, so this is the kind of thing that we need to approach, as allied health professionals, as a society, okay, as a society, and tell them, hey, but we have more detail, we have these guidelines, that can help us to implement and have direction. Okay, at individual level, I will be skimming through, okay, but obviously very important. I think very important is the screening tool, okay? The screening tool is an important situation that in certain institutions like Caring Grec and certain homes, okay, have certain screening tools, but many others do not have screening tools. Just for example, Mater Dei. Mater Dei is an acute hospital, which is a bit a different kind of game player, but a screening tool is mandatory. In Italy, for example, they have a mandatory screening tool for all people by law, So this is something where we need to get law, okay? Because if somebody sees it as a law, not as a guideline, they will be much more afraid. Okay? And I think in Malta, character-wise, we need laws. In Italy, there is a law in terms of screening tools. So a screening tool, so a person getting into an institution, they are forced, they are forced by law to screen the person for malnutrition. I've heard it, through other hospitals and other connections that we have, So why this is not mandatory? But as I told you, many institutions are trying to get in, but otherwise, unfortunately, it's not there, So remember, okay, if a person comes in, you look at his medication, his social history, and other things. If there is no standard into looking at nutrition, nobody will be asking a person, but are you eating all right? And actually dietary requirements. Sometimes we even miss certain allergies or intolerances, of a person. But it's important that you have a screening tool. And this guideline starts immediately, okay, with an importance of this screening tool. And like that, with the screening tool, you can immediately flag up a person with dementia coming into home and see if this progression is happening or there might be problems in the future, because this is the kind of thing. There needs to be follow-up. There needs to be monitoring. Okay? Otherwise, if you just do it once, it will be a problem and things might change. A positive screening tool then should be assessed, and this is important, okay? The point 9 is important because, okay, very good. We are discussing that there needs to be a screening tool. You do a screening tool, you flag it up. You might say, okay, we need a dietitian, a speech and language, but we don't have the person available because there's not enough. Okay, so it's not just flagging it up, but there needs to be, in the absence of certain professionals that are not available, okay, you need to have a bit of standard operating procedure. Say, okay, in that case, we do 1, 2, 3, 4, at least, but not nothing, So it's not just implementing a screening tool. You need to have a systematic approach on how to do it. Very, very important. I think there's a colleague of mine, Maria here, okay, 20 years ago, nobody used to weigh people, okay? So in the past, we used to learn by looking at a person and say, basically, they are 70 kilos or 80 kilos or 90, okay? So body weight is fundamental, So a person who gets into a home, gets into hospital, we always, whenever we have a referral, first thing, do we have a weight of a person? And nowadays we don't have an excuse of saying, okay, we don't have a hoist, we don't have a wheelchair scale, etc., etc. We need to weigh the patient, okay? And this is always coming on. Why weight is important? Because it's one of the easiest kind of thing to monitor the person and its progression, okay, of the disease. Because if they are losing weight, 6 months have passed and they lose 5, 6 kilos, in a person who is 50 kilos and should be 55 kilos, that's a significant weight loss. So weight, and this is in line with these guidelines, is very important to monitor. Mind you, as dietitians also, we calculate energy needs, protein needs on the weight of a person. We don't just look at a person and say, and there was on 1,500, you need 60 grams of protein. We have calculations, okay, we have guidelines on how to check the amount of calories that a person have. In all persons with dementia, individual habits, preferences, abilities, and behaviors shall be assessed and considered, I did it in italic, as far as possible. Why as far as possible? Because you cannot stay with a person one to one, stay there, check his preferences, and check it out. It will never occur, you know. So as far as possible, we need to have somewhere in their notes what are their preferences, especially if they are going in a long-term entity. Okay, but these are absent as far as I know. This is something that personally I never see. Personal habit, maybe social habit, used to live with, you know, with parents or that's it, you know. But preferences, we have nothing, you know, of the sort. So again, there is a lot of tools available, I think, outside in order to get these things and be checked in. And this is things. And very important is probable causes of malnutrition and dehydration as far as possible. Very important to see what is causing this. Okay, malnutrition sometimes is a silent thing. Okay, it doesn't occur immediately, but long term it will occur and it will have sometimes irreversible situations in persons with dementia. Okay, and this is much more related to a bit of an advance, you know, stage 3, 4 and over, you know, of dementia. um, should not have dietary restrictions that may limit food or fluid intake are potentially harmful and shall be avoided. And this is very, very important. Sometimes you find other healthcare professional. They will see the history of a person with the dementia, and they have diabetes, they will have, you know, cardiovascular disease, and they will be restricting food in relation to that disease from the hope, you know, that obviously they will control better the diabetes. Mind you, I'm not saying you give them whatever they want, you know, if the diabetes is not well controlled, but you need to change the situation of like, first is the food, because that might be a problem, and the poor appetite might, and then check other things. Just let me give you just a small example. Somebody with cardiovascular disease, they are on the pill statin, you know, to remove cholesterol, and somebody that has no fats, because you have, you know, cholesterol and you should not have fats. On the contrary, we promote fats, good fats, you know, um, better fats, but fats is not contraindicated in people who are losing weight. In fact, we use it as part of a food fortification in our meals. So you need to change the concept of like the most important thing is the maintenance of the weight and no further weight loss. So this is very important, not to restrict, you know, like for example, gout. You know, sometimes they have gout and you go for a low purine diet. No, not really, you know, in people with dementia. So again, very important to take care of that. Very important from a medical point of view that medication should be reviewed. As far as I know, we have good geriatricians, you know, these days, and they review medications for polypharmacy. And obviously, in relation to our topic, if this will be affecting their appetite. Okay, so it's very important in that. Okay, should be encouraged to share their eating and drinking occasions with others to improve quality of life. Okay, so this has been, you know, well researched that, you know, eating in a community is much better than eating on your own. Okay, so this is something that needs to be done. Sometimes when people are sick, you know, they have a condition, they most of the time leave them in the bed, you know, not to have falls, you know, other situations. So sometimes that needs to be not avoided completely, but at least not prolonged. Okay, because many times we leave that for a longer period of time. I saw people 6 months, you know, in a bed because they had, you know, an infection in the toe, for example. Okay, so you don't leave them there just for that sake. Persons with dementia and impaired eating ability should be offered support and assistance during eating and drinking. Okay, this is important, especially from a carer point of view. Okay, how are you going to assist? So there are situations where the older person with dementia, especially with refuses food, you know, refuses food. So it's important that the carer that doesn't say, all right, she's refusing food, what can I do more, you know, and stop there. It's important that the carer, you know, sees how often this is happening and needs to flag it up. Why is it important? Because like that you can, you know, go, the person can be reviewed by a dietitian, for example, and offered other food for special medical purposes, other modified consistency food, you know, or other things which needs to be there, you know. So it's very important not to just say, she's refusing, well, that's it, you know, this is what she eats only. Okay? And very important, in line with that, is the monitoring of the weight, because that is an indicator of saying, okay, the poor appetite is affecting the body composition. Okay, and persons with dementia and impaired ability should be offered appropriate eating or drinking utensils to support independence. This is where OT, okay, I mean, some people have arthritis, for example, and other things, and this impairs, apart from the dementia, impairs the eating in itself. Okay, so it's very important that these are offered, referred appropriately, for example, to an occupational therapy, okay, or other health professionals to aid and support this food and drink. So the aim of these recommendations, as you can see, is to, as much as possible, first of all, screen, flag up, and do an action. You have an action of something, not just say, okay, memx tagħmel. I mean, this she's a bit of a person, difficult person. This is sometimes what we say. Okay, difficult person. She always refuses, things. But very important to offer other alternatives. Okay, and obviously this is an example, I'm not going that much into detail, of things which you can do, for example, when there are problems with eating. Very common, and I have encountered it myself, is, for example, oral health. Okay, my mother, when I was abroad for 2 or 3 weeks, her dentures were never removed, for example, always stayed in the same place. And when I went, her oral health. So obviously that will impact poor eating. Nobody eats with a very bad mouth, or everything. That will repel you. So that will be an easy kind of thing. With that, with oral health, definitely, the eating will improve, even the taste, and everything. So small things. So there's a lot of things which one can actually assess. Mela, the training part, these are the individual part where the training is important, okay? So the training goes on to 2 levels, okay? First of all, the carer, as we're saying, the carer, they are at opera, but even their training, especially if they are in the moderate part of the dementia, okay? So it's not just telling them eat, but you need to train them in an approach where they need to listen. For example, my mother has she's in the 4th stage of dementia. Okay, so I need to repeat many times. When I in the 1 hour, half an hour that I'm there, I always repeat the same thing. And sometimes you feel that I'm repeating and she's not listening. Okay, it doesn't work like that. So you need to be aware that even from the carers in that person who is diagnosed with dementia, these approaches are done. And this is why it's important that we know that the person has dementia. Sometimes we don't know if at what stage they are with dementia. When they are at stage 5 or 6, you say, oh, they have dementia. Huh? Ecco. That might relate it because ecco. That's related many times. If there's a medical condition, for example, a very common thing that happens is UTIs, urinary tract infections in older person. So if she has an infection all the time, but they are not going to test it every time, the UTI. Sometimes they have urine sample. Sometimes you can, because of the smell. But if you have these repercussions and you have these spikes of infection, then this on and off situation comes up. Another thing might be what kind of dementia, the cause of dementia. It might not be Alzheimer's, it could be vascular dementia and other kinds of dementia. So again, you need to see why this is happening in that individual. Okay, so persons with dementia, risk of malnutrition should be frequently offered drinks, additional strengths. That we said that persons with dementia should be offered routine oral care. And this is where 2 important things are an important. They should not be offered any stimulants, So sometimes you read articles and you find, even abroad, stimulants like drugs, in order to increase their appetite. In dementia, it is not recommended. And it's not recommended because there's no evidence at all that the dementia will, improve or the food intake will improve with the stimulant. So no pharmacological things should be given or offered or promoted with people with dementia. Okay, so it's very important. And person with dementia, it's written down, okay, that they should be offered individualized dietary consultations, okay, by nutrition expert. In our case, Malta dietitians are the profession that actually review. And I'm going to take, 2 minutes, to give you an idea of what is our job also as dietitians, because many times people think that dietitians go there and just, say, okay, you need 1 supplement, 2 supplements, or increase the food in general. Okay, what we do, we have a systematic approach. Okay, we look at, we screen patients, they are flagged up. We get into the primary past medical history. We look at the drug interactions with the food. Okay, we look even at nutritional diagnosis, is called, where we see the cause of the situation. And from all that information, which sometimes we don't find all, okay, we get a plan and intervention individualized for that person. So it's a process, okay? It's not like just going there, we have this nice meal plan, okay, and we give it all I mean, to other people, or this is good, or this is bad. It doesn't work like that. You know what I mean? I mean, if it was like that, I wouldn't be in this profession because we're not their paper kind of thing. And remember, these days people search for things, even older adults themselves. So it's very important to see what evidence, what data we have in order to give them this individualized things. Very important in the process is the monitoring, is the evaluation. Sometimes we give an intervention and that intervention does not work. So we have contingency plans. So this does not work, so let's try this. So it doesn't mean there's a structured kind of protocol and we just give people, say, okay, you need 1, 2, 3, that's it. Okay? So it's very important that you are aware that we have this kind of systematic approach. Okay, again, compared to that one, flavor enhancers are not indicated. What do I mean by flavor enhancers? Okay, giving them more sugar, giving them more biscuits, in order for them to feed them instead of food. That's a completely wrong thing, okay? Because, the taste enhancers like salt and sugar, okay, is much more palatable, in terms, but they will not give the nutrition that is important. And protein, for example, is an important thing. MSG. Tell it how soon I will be finished so that we can discuss it. MSG, yes, definitely. Okay, so very important is not to routinely offer this. Doesn't mean no treat. Don't get me wrong, but not she's not eating when I offer her biscuits. Okay, no problem. I mean, it's a substitute. It's not. Okay, nutritional wise, it's not. Should be offered fortified foods and drinks to increase energy and protein intake. This is the first line that we do. And that is an institutional level, this is what we try to do. I remember in the past, like Zammit Klep and other institutions, they used, in terms, chefs used to include protein with all the foods. We know that there's 10 grams, 15 grams of protein, and they will be all included in foods. So at an institutional level, if you can assess what's happening in that institutional level, you can actually promote that one and be sure. Fortification doesn't mean increase food intake. Fortification means that you keep the same size and you're increasing calories and protein in the same size. And remember, when there is dysphagia, swallowing problems, and the consistency of the food is altered, the calories and the protein will go down. Okay, so this is a normal process. So you need to fortify. Instead of water, use milk. You increase the protein. Sometimes people think this is another very common thing. They give protein, okay, on its own. Okay, protein on its own. In the absence of no energy from carbohydrates, the protein will be utilized for energy. It will not be utilized to build up your body. Okay, and that's a big mistake. So sometimes it comes from healthcare professionals, that they will be prescribing protein because they're losing weight, but we don't know how much they are eating. Okay, and that's a problem because the protein will be utilized not for muscle buildup, but it will be used for energy, for normal energy, and nothing else. Okay, so persons signs of dysphagia or chewing, very important to refer and change texture modified. I think this is something that is happening, that they are referred, okay? We remove, dietitians work well with the speech and language therapy, and obviously with the modification, we fortify the food or supplement other food in order to get to the energy requirements and protein requirements of the individual. Persons with dementia or at risk of malnutrition should be offered oral nutrition supplements to improve energy and protein. This is the first line that we do. We don't just go there and just say, okay, 2 supplements. There are these supplements, these Tetra Paks. I'm not going to mention companies, but it's not there. You say, okay, we have the supplement, take them. Because many times they don't like them. They will repel them. It's not, again, if they are hot, many times they are not palatable. So the more colder they are, sometimes they are much better. Sometimes they are left in the Tetra Pak or in the bottle just there in front of them, and that's it. I mean, getting it into a glass is much better. Okay, and getting that supplement into a pudding, or something else, like here in Malta, we do jelly, for example. Okay, it could be diet jelly because if somebody is diabetic, and you put the supplement there, and it's like a pudding. So there are different ways rather than just offering the supplement there and that's it. Because many times that might be repelled. Okay, persons with dementia should be offered nutrition supplements, and as we said, nutrition oral should not be used in persons with dementia to correct cognitive impairment. Remember, this is an important point, that over stage 3 and 4, we're not trying to target the dementia here. Okay, we're not trying to say, okay, let's cut down the progression. That, according to research, is very difficult because it's a progressive disease, okay? If the disease is there, it's not easy to cut it down. So we don't use oral nutrition supplements, say, okay, she's a stage 4, so we try to prevent that she goes into stage 7. This is the idea of this phrase. Okay, we're soon on the 40s. So dementia-specific oral nutrition supplements are not routinely. Nowadays, these food for special medical purposes, there are different ones, and many companies are targeting specific diseases. At the moment, there is no specific supplement. They say, okay, in Malta, we should have a supplement, an oral nutrition supplement for people with dementia. Okay, it will not occur. Why? Because our aim is to increase the energy, the protein content, the minerals, vitamins of that thing. There is nothing like a phytochemical or something which you need to supplement as a functional food in order to prevent the progression. Okay, again, you see articles. Okay, this is why it was put in there, like ketogenic interventions. I don't know if you know what is ketogenic. Ketogenic is a high fat, okay, diet where metabolically you'll be using fats instead of other carbohydrates or protein as energy source. So usually in cognitive impairment, something related to neurodegenerative diseases, many times there is some literature stating that this might help the decline. At the moment, as far as these recommendations go, we don't recommend. And the idea is that, first of all, there's no big backup on the situation, even though you will find, okay, you'll find some articles stating the possibility. Possibility does not mean that it's going to happen, So at the moment, any ketogenic interventions like change completely of their diet is not recommended. And again, omega-3 fatty acids is another supplement that is related to inflammation, to infection. Again, it's important to have it, but not with the target of trying, to remove or, halt the progression of the disease. So this is why it's saying, I'm not saying an omega-3 is not good, but not with that things. And same thing with probiotics. These guidelines mention these because at the moment, probiotics and omega-3 are very researched supplements, food supplements. Okay, so there's no probiotic. Obviously, if the older adult with dementia does not have, for example, IBS symptoms or constipation, if you're targeting constipation, then it's okay, but not targeting the dementia. Okay, so there's no probiotic targeting that. And person with dementia should not be offered micronutrient supplements unless there is an indication of deficiency. This is an important thing. Many times in older people, you immediately state, we are who have vitamin mineral supplement, no problem, okay? But that needs to be assessed vis-a-vis the oral intake, okay? If the oral intake is low or always on the low side, or you think that the food that is being offered does not contain the vitamins mineral supplement, then again, there you supplement accordingly. So this is what the guidelines are trying to state here. Okay, very important, I think the point that our colleague stated, that there should be no parenteral or enteral nutrition in, end stage kind of dementia. Okay, so you don't say, she's not eating, so we go for parenteral or enteral nutrition. Obviously, if there's no critical, situations for that individual, or it's in the early stages of dementia. So enteral and parenteral nutrition and fluids shall not be initiated in person in the terminal phase of life. Okay, very important in the guideline. Enteral nutrition should be used temporarily in persons with mild or moderate dementia. Okay, temporary. Okay, so they go into hospital, they are not eating, they had a gastric, maybe operation or something, and they need to be given, oral because the gut is not working. Then that's okay, but temporary, and you don't just say long term we give a peg, okay, and we leave them with a peg long term. So it's very, very important, and I think this is consistent in these guidelines. Enteral nutrition shall not be in sharing patient with severe dementia, and parenteral nutrition. Parenteral, for those of you who don't know, if the gut is not working neither, you can give nutrition through a vein, directly through a vein. Okay, usually it's done after certain operations where the gut needs to heal. Okay, and those are the last resort that when you have intestinal failure, the intestine is not working, then you need to use this route. So again, this needs to be done at every and last two, okay, 40 recommendations, okay. Again, persons should be offered an individualized, multi-professional and multi-component approach to support food and fluid intake and maintain or improve nutritional status. So again, here, the dimension of a multidisciplinary approach is very, very important, okay? I think this is something that sometimes is missing. We refer sometimes to people rather than working in an environment where everybody's working there on its own. I'm not saying that all places are like that, but certain cases, we don't discuss together. We just write notes, and then I need to interpret the notes, then I need to ask, and then the note might be interpreted differently. So it's a bit of a mix and match situation. So I'll conclude here so that we can have a bit of a discussion and any points. Okay, malnutrition and dehydration both together are major concerns in dementia. Okay, and very important. These guidelines are showing us 40 recommendations to try to tackle this. And I hope that with such guidelines we can put them into standards, or put them into strategies. This is the idea of reviewing, our guidelines and standards. Okay, individualized nutrition plans improve quality of life, and this is not because I'm a dietitian and say, okay, my plan works, but there was a lot of research study that the more individualized approach, the much better. Remember, in long-term facilities, okay, there's more that individualized approach because you would know more the client, okay, but very important that to know the client, you need to have assessment and data on that client. What is happening, I think, in Malta many times is that many of the carers, correct me if I'm wrong, as I told you beforehand, is that there's a big turnover. Okay, sometimes you find 6 months carer, then 6 months passes, another carer. You don't know what you need to restart again, and this is in long-term institutions. So that time of like having a nurse, or a carer who and who works in a facility for a long period of time knows the person has changed a lot, in the previous years. Okay, very important that institutions must prioritize care and support. I think this is something that needs to be done. Okay, in terms of standards, and caregivers obviously play a vital role. More than allied health professionals sometimes because they are doing the routine care all the time. They will know better the person. They need to flag up if there's a problem. These are the person's first line that needs to do things to do these guidelines, and adhering to the guideline ensures better patient outcomes. And this is why every like 5 6 years these guidelines are put on, okay, in order for us to have a direction on what is available. Just one note, these guidelines are done in a systematic approach. This is not a guideline that 6 individuals think these are the best recommendations. They do it in a systematic approach, meaning, okay, that they will be reviewing what is there, okay, in a way, okay, that is evidence based. It's not like my opinion. Okay, so I think these guidelines are strong in order at a European level, okay, we see what is the best way to do. Okay, obviously there needs more research and more studies. We leave that to the academics, okay, in order to have more data, in order to see what I'm saying, is it true or not. Sometimes this is what's lacking, even from an admin point of view and from a financial point of view. Many times what happens is that, but we know if this is happening or not. Do we know if people are malnourished in dementia? I don't know, maybe I'm wrong. There might be studies, locally, but I think the more evidence we have, the much better we can argue that we need more funding, we need more carers, we can sponsor training for carers and other things which we have highlighted in these guidelines. So thank you for listening. I will open the floor for any questions or any queries. Definitely. Yes. To tell you the truth, as dietitians, for example, I'm here giving this talk because me and other part of the team wanted to tackle, certain conditions like dementia, and one of them in order to promote the importance of nutrition. Now, the only thing that I suggest is that now that we have OPSA, which is the standard of aging, and we go there, we do meetings, might be even the society, gets on, and we tell them these are there. How can we implement them maybe in the next turn of guideline? Or we do supplemental standards. Sometimes the standard goes up, and you can top it up, to say, okay, that section, will have that kind of thing. This is the way how to do it, because to tell you the truth, aging is a big, big topic. Dementia is one thing, one situation. So what we need to do with these guidelines, I think, okay, is to push through these agencies in order to say, oh, these exist. How are we going to do it? Always remember, okay, that when you're implementing something, you need to see if you have the resources, if you have the time, because as I told you, we can implement a screening tool, but then we don't have dietitians working there. So it's useless saying, okay, let's implement it, and then you don't have the stuff. Things needs to be supplemented and see the whole, the wider kind of thing. But a society like yours, dietitians, other health professionals doing a guideline and presenting it to standard authorities, I think is the first approach to do. Mhm. As I told you, exactly. In the interim, you definitely ilek issa no enter in. Okay. Eżatt. In the past, ekku. Mhm. So I think that one is a bit, it's there, I think. And I think it's something that is easily recommendable, much easier. I think with geriatricians now, with more geriatricians, because in the past we had few, I think all these kind of things are done. I have experienced also this. That's a question that is part of my last slide that we need to research that. So for example, you take samples, of the food, in homes because it's reheated. It's a cook chill, kind of situation. If you're going to cook it, how much of those nutrients are still there? Big question mark. Okay, protein and other major nutrients should be there. But then another question, we've done a small study on that in Mater Day. How much of it is being consumed by the person with dementia? That's another question mark. Okay, do we have a protocol in stating she ate half of the food, quarter of the food? When I all of man. But remember, what my take-home message for today is that people with dementia are more at risk of this malnutrition. So I'm saying older adult in general has poor appetite, has everything, but does not have dementia, for example. They are at risk. But people with dementia, since it's a progressive situation, they are much more at risk. So we need to flag them up much easier. Shall I sit down? Sorry, I'm joking. Are, are they listening? Oh, yo, namel al-microphone.
My mom went into an old folks' home 6 years ago. And back then, it was common to be allowed 12 hours visiting hours. So I could go see whether she was really eating, whatever, and check on a lot of other things. But now, in the morning, we are not allowed to be there for the 11:30 a.m. meal. Now I know that my mother, when she was her normal self, she would usually eat most in the morning and in the evening, where we are allowed to be near the evening meal. She didn't really eat much. So I don't really know what's happening in the morning. And another thing, about 10 years ago, I had an aunt in another institution. And this institution, well, it was in Mtarfa. I don't know how it is today. But back then, they had a small kitchenette with every room. So I could actually, if she felt like having a boiled egg, I would actually cook it there and then. My mother also likes boiled eggs, but where the hell can I, bake them fresh? I live in Dingley. I depend on buses. By the time I get her, I don't even try to do because I know she'll get, but what the hell have you given me? You know? Uh, uh, and the other thing is, I believe a lot that exposure to linear sunlight is important for nutrition too. Now, where my mother is staying, they have a yard, but it's a small yard, true, adjacent to her room. But even I am not allowed to go out there. So these things really angers me. And my mother, I mean, she can only go now out in a wheelchair, so I can't really take her out unless I have a special whatever, which I cannot really afford. And it's these kind of things that I haven't seen those kind of recommendations because. And one last thing, if I may, when my mother was 78, she had breast cancer, and the first thing I was told, don't give her anymore ever vitamin supplements. So even that is a sort of problem. And what about all these, things and everything. Now, my mother has a stoma bag. So I know that she won't really get certain nutrients, but for about 3 or 4 years, she was given 2 vitamin C supplements every day. And even what that supplement given to pregnant women and the exactly she was. But now it seems that they don't give it. I don't know why.
I mean, valid points. All what you have said is all integrated in there. For example, let me give you an idea of the food. So in terms of, not allowing relatives during the dining experience, it's a policy that is done for several reasons, and it's not easy to change it over. But imagine you have a record. So imagine you go to your mom and you have a record there of what she has eaten or not. At least having a standard, okay, into doing mandatory food record charting. Okay, so there will be a standard kind of thing. Say she ate half of this or this one. Last time I went to a home, and they gave us, for example, a booklet with the nutritional data of all food, of the food, and that's what I told to my colleagues. Imagine, I know the soup has, this amount of proteins, this amount of fiber. I mean, the most important thing is how much of that did your mother or your relative eat. That's the most important thing, not having the nutritional components of our food. Not even for us, it was very difficult because for every food there was like proteins, as if people know the numbers when we do food labeling and we go to supermarket. Sometimes it's very confusing. Imagine doing that. So certain implementation in relation to food intake rather than insisting that relatives should go within the dining experience. Because remember, what's happening is that the dining rooms are not big. So imagine every relative is there with the dining experience, it will be chaos. Okay, so I think that's the reason why also. So that's recommended, Mela, some homes are, when in hospital, I'm imagining in an acute hospital, it's a transient kind of time. My mom has been 3 weeks, in a hospital. But what we need to think in long-term facilities, there should be, I think it's part of the standard, correct me if I'm wrong, that there should be a dining room. And as much as possible, the person needs to eat in a dining experience. So if that's not happening for 6 months, you told me, you need to see the reason for it. It shouldn't. It shouldn't. Okay. With regards to the supplementations and everything, certain, as we said in the recommendations, certain supplements in cognitive decline, might not be effective, and there's no need to give them, compared to when she had breast cancer, for example, or other situations. So things might have changed in terms of recommendation. And many times, certain supplements, even folic acid and other vitamin supplement, may interact also with other medications. So that's why they might not be doing. I'm generalizing because obviously I don't know the case. And what were the other points? The food dining experience, the supplements, and uh, that's that one is nowadays because of the older. What happened is that since there's this big influx, which we knew of older persons, I mean, the numbers are huge, and this is why dementia is increasing. You cannot have those facilities. Even, for example, I agree more with a kitchen, in every home. Okay, cooking there, we are experienced when we're abroad, but it will not happen. It's very difficult to happen. I really wish, that in every entity there is a kitchen, because you can liaise with the chef. We can liaise for modified. It would be much more a personal experience. But I think it's used, man. Emma, when the numbers were low, now all these numbers, it's not easy. Yeah? I mean, I agree with that, but I think it's logistically it's not going to be easy. Father.
We have masses in different wards. So one of the nurses accompany me, and she will tell me, for example, just have a host, father, or quarter of a host to this particular person. Okay, so that's what I have to do. I'm still a bit confused with regards to food brought by the relatives of the sick. I'm not so sure if they have an idea of the diet it is somehow offered. So Where do we stand? Where do we stand? That's my question.
In fact, one of the recommendations that we were flagging up is this, what in America they call it liberalized diet. Okay, so when you have poor appetite or decline in food intake, you do a liberalized diet. Now here in Malta, we're lucky that many of the relatives are visiting. And giving the food themselves. It's a good question, because if, for example, the dietitian goes on an individualized approach, one of the things that we do many times is phone the relatives and tell them, what do you bring? Sometimes they are there and we have an idea, because if you bring a packet of biscuits is one thing, but some people even bring cooked meals, and that might also be a problem, because if the meals are not cooked well, if the meals pose infection, the person with dementia might be more prone to infections, or food poisoning. So again, these are all part of in relation to making standards. Okay, so in a nutshell, okay, and latching both of your questions, is that we need to have documentation of food intake. We have documentation of how much nappies they are using. We have documentation on when the clothes are washed, but we don't have documentation on what actually are they eating. We cannot make it complicated in a food frequency questionnaire kind of survey and every dot. But for example, hydration, for we should have records, like we're in a hostel, how much of the fluids the person. Many times I go to a home with my mother. How much did she drink? I know, because I know that I had 6 bottles, and she and maybe she had 2 coffees. But how much of that coffee did she have? So documentation is the key. Okay. So if we have a documented, the person who goes with the tea or the coffee goes there and then makes another round and see if that coffee, she took half of it or half. For her, she offered coffee and that's it. Now a mug is 300 ml. Did she have half a mug? And there will be a chart somewhere and say, okay, 200, 300. No big. So it's not like something huge. And same thing with relatives. Imagine I'm the relative. I go there. I have this chart in the room or near the bed of a person, and I write down and say, I gave her 2 biscuits. I gave her this one. And like that, it's record. So, but charts, dawk il-charts mhux ma' sodda, imma ma' something similar, exactly, what I mean? Issa kollox GDPR u kollox u these days, so. Mhux hekk. And and then I ask how much, and actually nobody exactly know how much. This is my issue. Definitely. And in dementia, because this is our topic, it's much more important than normal aging, like normal older adult aging. In dementia, it's much more important, because you will be telling her, she says yes for 6, 7 times, but in reality, she will not be doing it, because of dementia. Okay, so it's much more important. So my idea, at least looking at these recommendations, is to have a system that in our home we have 60 people with dementia, for example, or 50 people. In those 50 persons, you need to do 1, 2, 3, 4, different from the others. I'm not saying other similar cases are not done, but in those particular cases, at least there is that standard, that SOP, whereby you can do these simple things. It needs to be simple, because remember, many of the carriers, they are sometimes understaffed. Okay, this is again another thing. The ratio of staff, to patients. Sometimes, I mean, it's incredible. You're in a floor and you see nobody. At one point. So again, what is this stuff? This is where standards needs to, go in and state, if we don't have 3, carriers in one floor, I'm imagining that these things will not be done then. It's very easy to say they need to be done. Yep.
Hi, we're here from the OPSA. I think it's important that we delineate certain misconceptions. The madam at the very front said that they should push towards a dining area, they should push towards lighting. These are in the standards, and I have them actually in front of me. In this one standard, it outlines that every home must have a dining area amongst the community area and leisure area, etc. Outdoor, no. That's no. However, every residential home must be well lit, either with sunlight, natural light that is, or at the very least warm yellow light. That's from our end. Yes. From our end, enforcement efforts are ongoing, work is ongoing. That being said, I do need to delineate. We have the standards for every single residential home. However, each home has its own policies then. So it depends on what you sign. For example, we cannot say that a residence should have a kitchenette. We just give the standards, what every home should have, no matter the pricing, government, etc. So we need to just to cover our backs a bit. On the other hand, the OPSA is quite young, from 2023. So give us our due time as well, because there's a lot of work to be done, not just in this area. So bear with us, but we hear you loud and clear, and we're I have taken note down to the citations, don't you worry. Please. Mr. Fennick, that's right. On our part, we're not saying that they're perfect, but we implement. Don't you worry, we implement. Can I also ask, because I'm from the standards department specifically, and part of our job is to undertake research. You mentioned earlier that there are specific nutrients being pinpointed to have a role in dementia. Yes, the research gap. But if there's an area of interest out of these nutrients specifically, thank you very much.
Here, okay. Thanks for listening. It was a pleasure meeting you all. If somebody needs the slides and everything, I can do a PDF. Do it, and no problem, because I was seeing a lot of yes, definitely. In your hands. Thank you.
Yes, over here we have some leaflets. If you're not a member of the society, please do become a member, because you will receive everything from us. We do have a number of activities for people living in the community as well, which are all free. First of all, thank you very much to Mario for an excellent talk. And I think this is the beginning, because we need to work on this and with you people as well, the OPSA. So yes, do come and pick up a leaflet, an application form. We have another talk next week on the 2nd of April of LGBTIQ. This is very important, especially for care homes. It is at 4:30 at Portiuncula House, Portiuncula Care House in Baharacha on the 2nd of April. I highly recommend all care homes and everyone who works in the dementia field to come, because this is something that we need to be proactive about and not reactive. So please do pass the message on. I don't know if anyone has any other questions, but we have a number of activities here and our leaflet if you would like to come and talk to us after. Yes, very much so. It was really excellent. Thank you to Hospice for hosting us.